Hello everyone, this is EMT 204, Pediatrics Overview number 1. We're going to talk about age-related development in children, and we're going to talk about anatomical and physiological changes based on age in children. And one thing to remember when we talk about developmental milestones is that these are guidelines. Some kids meet them early and some meet them later. And the best information that we can get about how a child's mentating and how healthy they might be is by asking the caregivers. So is this normal behavior for the child? Or is it not? And try to get objective information, just like we do for our nursing home patients or our adult patients with an altered mental status, is try to gauge what is normal for them and try to get some objective information. They can normally speak and now they're not. So try to get tidbits like that. So there's a few important milestones that we'll discuss that relates to how sick or not sick the child is. But I don't expect to remember all of these. We'll focus most on the important ones. Okay. So birth to 2 months. So it's a common saying is that for the first 2 months the babies eat, sleep, and poop and pee, and that's pretty much true. So limited interaction and comfort being passed from person to person is actually normal for that age. And what is normal is that they can turn their head and they can control their gaze. So if you hold something in front of them like a light, they should be able to follow it with their eyes. They cry to communicate needs. So they will, when they're hungry or they have to poop or they have reflux or something, then they will cry to communicate with that. And then the parents are sort of scratching their heads, okay, why are they crying? And you sort of go down, check those three things. So they develop trust in their parents, but they don't really have stranger anxiety yet. So birth to 2 months, they can recognize their caregivers, they'll make eye contact, they sort of start to develop a personality. They'll smile, they'll sleep through the night more. The birth to 2 months, the sleeping is mostly during the day, so it may be completely normal for a 1-month-old to be sleeping at 2 o'clock in the afternoon during your assessment. And that's, again, you ask the parents, is this normal to sleep now? But by 2 to 6 months, they should start to sleep at night some more. And you would expect them to be awake more during the day. So again, normal, abnormal. If a baby's really sleepy and difficult to arouse in the middle of the day, for a 3-month-old, that's different than if it's a 1-month-old. So they'll actually, you can play peekaboo after about 2 months. They'll have joy. They'll get afraid of some things, and they'll show surprise, and they seek attention. So 6 to 12 months, they can start to sit up without support, which, again, you want to ask if this is normal for them. If they can't sit up, if they're they appear like listless or have poor muscle tone, that's abnormal. But another trap that you want to, when you look at this, is you don't want to point out the developmental milestones that they should have reached, and say memorize the checklist and say, well, he's 6 months old, he should be able to sit without support by now. Don't do that. This is going to upset the parents. And again, just go back to what's normal and not normal. So 6 to 12 months, teething begins. When teething begins, there's a lot of secretions in the back of the mouth. Kids are more prone to ear infections. They'll start to babble. By 12 months, they should say a word. And again, don't say, oh, your baby's 12 months old, they should be speaking by now. That's not normal. So ask the parents where they are developmentally. They're curious about things. So 6 months old, if you keep toys in your pocket or a pen lights are good. You can hold up your stethoscope in front of them. And this is when they develop stranger anxiety. They'll have tantrums, and then they can also eat on their own, so some soft foods. So one of the things after about 6 months old, when you think about separation anxiety, is before 6 months old, the baby can be passed from person to person, and they'll just be smiling and they'll be interested in things. But then 6 months is when they really develop an attachment to their parents. So this is where it's really important to assess the patient with the parent if possible, like while the parent's holding them or when they're on their lap. One of the things you can do is test something on the parent before you apply it to the child. So if you're going to apply the pulse ox probe, you use there's a Band-Aid pulse ox probe. put that on, there's a shiny light, so you can show them the light and hold that in front of them and get them interested in the light, and then gently try to wrap it on their finger or their toes. And you can also put it on the parents' fingers, which tells them that it doesn't hurt. If you need to listen to their lungs or listen to their heart, you can listen to the parents' lungs first, let them watch that, and like, oh, now you get to do it. So those are some little tricks you can do in the 6 to 12 months old and later in toddlerhood. So that's infant. Infant's birth to 12 months. Neonate is the first month of life. And with the neonate and the infant, they can't support their head. So when we pick them up, we want to be really careful because their head is like a bowling ball on top of a broomstick. So if you pick it up and you're not careful, the head can just rock to the side or to the back. So you sort of pick them up by the shoulders and hold your fingers up behind their head to support their head when you pick them up. The parent's going to be really upset if you're not careful. I have the parents hold the child as much as possible. So if we're going to the ambulance, the parent carries the car seat. If the car seat's in the ambulance and we're carrying the baby out, the parent holds the baby. I try to engage the parents into doing that as much as possible. Okay, so the toddler. Toddler is ages 1 to 3. By 12 to 18 months, they're crawling. They start to walk. They'll have some teeth in the front. They'll start to imitate others, and they start to do make-believe. They know their major body parts. They can speak 4 to 6 words. They develop object permanence, and there's a lot of separation anxiety between at 12 to 18 months. So from 18 to 24 months, then they'll be walking better. They'll run. They may climb up onto things. They may climb out of their crib. And then the body starts to catch up to the head. They understand cause and effect. So if they cry, they know what kind of effect or how the parents will respond to that. They can label objects. And then they develop attachment to a certain object. So if they have a pacifier, they'll have a special doll or a special blanket. They'll be attached to that. So it'll be really helpful, and the parent or caregiver will know what it is, to keep that with them. Let them ride to the hospital with that. You can also do your exam on their doll or their blanket. So before you assess it on them. So use your stethoscope on the doll first. 12 to 36 months, they develop fine motor skills, maybe potty training. They'll go up and down stairs. They'll jump. They can follow commands and name a color. And this time they're curious, so some of the separation anxiety may go away, and they'll actually be interested in you, and more so than at the younger age. So a strategy, so we would also want to examine on the parent's lap. We want to get down to the child's level. So one of the ways, the techniques you can use is to really get down, try to avoid standing over top of them, and have a parent assist. So preschool age is 3 to 5. They become verbal and active. They respect modesty. Preschool age child is ages 3 to 5. They become more verbal and active. Now you can ask the child questions about what's wrong with them. So you can ask them where their belly hurts, or if it's hard to breathe, and they'll be able to answer. So you want to involve the child at this age. You don't want to. You want to definitely ask the parents what's going on. But in addition to that, you want to ask the child and involve the child in their care. So school age is ages 6 to 12. So they start to understand death at this age. Maybe they've had a pet die, or they've had a relative die, and they sort of understand what that means, and that there's fear of that, and there may be fear of healthcare workers. By age 8, their anatomy is similar to adults. So when we talk about later, we're going to talk about the airway and sort of the ribs and where the abdominal organs are and related to the ribs. And by 8, their physiology is to adults. So you want to explain steps in simple language. If you say, I'm going to take your blood pressure, they may interpret that as you're going to take something from them. A better choice of words is, I'm going to check your blood pressure, or I'm going to, do you mind if I assess your blood pressure? So they're very literal. And so you want to use simple language, but you also don't want to talk down to them. Okay, adolescence is 13 to 17. So with adolescence, you want to offer them as much control as you can. So give them two choices, and either of which are acceptable. Would you like me to check your pulse or your blood pressure first? And try to offer them to help, and get down on their level. Avoid talking down to them. Just understand the situation that they're in, whether they're in school, if it's a social situation, if they're at home and they had an argument with their parents. One tip that I would recommend is, if there's any kind of audience, get them away from the audience. Whether it's their parents and there's a difficulty with the parents, or they're in school, they're in a public place. Everyone's excited. Just get them in the ambulance and assess them there. And try to have a chaperone with you, or at least have another caregiver with you. But get them. A lot of times, once you get them away from the audience, it's just a lot easier to assess them, and you'll get some more information. The story may be different, especially about things like drug use, or if it involves sexual activity. The story may be different when you're in the back of the ambulance than it is when their parents are there watching. Okay, so now some of the anatomical differences. We'll start with the head. So heads are relatively large compared to the rest of the body. So with the large head, when we position the airway, if we lay the child flat, their head could actually flex forward and include their airway. So what we need to do is pad underneath the shoulders, especially when the children are younger. That'll keep the airway properly in line. So for the first year of life, the anterior and posterior fontanelles, so the sutures in their head behind their skull, are open, and that's a great tool to assess their hydration status and intracranial pressure. So you'll see the fontanelles will be bulging if there's increased intracranial pressure, whereas if they're dehydrated, their fontanelles will be sunken. You can actually see them like a depression in between the sutures of their skull. So those close at around age 1. So for under age 1, that's a good tool for assessing intracranial pressure and volume. Okay, so their neck is shorter and their airway is smaller. So it's more prone to an upper airway obstruction, which can either be from the tongue or from an object. So children, they're curious, they put things in their mouth, more likely to form an obstruction than with adults. So the epiglottis is long and floppy. So when we think about if we're trying to intubate and we're using the curved laryngoscope blade, the epiglottis may flop down and obstruct our view, although the American Heart sort of backed off on that and said it's okay to use a curved laryngoscope blade, but that's just a consideration. Children are obligate nose breathers, so they could be in significant respiratory distress from just a cold if their noses are clogged, and they can be cleared with suctioning. So that's a simple solution that I remember I shared with. I had a child I was concerned about because it looked like he was really exerting himself to breathe, and we got to AI, and they did a suction. They put a suction catheter down his noses, and as soon as his nasal secretions were clear, he was like 100 times better, and he probably got discharged a short time later. He just had a cold, but his work of breathing was increased just because there was mucus obstructing his airways. Now, we generally don't deep suction, but we do have the bulb syringe that we can use, so consider keeping the narrows. Remember the nose when you're with your treatment plan. Okay, so the respiratory system. There's a smaller tidal volume, but there's double the metabolic oxygen demand. There's less functional residual capacity, and respiratory rates are normally higher. That means is when children stop breathing, they have less oxygen remaining in their lungs, so they're going to desaturate faster. So if you think of the oxyhemoglobin dissociation curve, with children, that's going to be to the left. They're going to desaturate faster than healthy adults will. And with that, the body is also more sensitive to oxygen deprivation. So the normal pediatric respiratory rates for neonates is 30 to 60. 1 month to 1 year is 25 to 50. And so you think about high respiratory rates, that's normal. So if there's a little bit of distress, that's going to be even faster than maybe 1 per second, and that's not something that we necessarily need to worry about. If their work of breathing, and when we get into respiratory, we'll talk about differentiating respiratory distress from failure. From toddlers, it's 20 to 30, preschool 20 to 25, school age 15 to 20, adolescents 12 to 20, and adults it's pretty much normal respiratory rates by age 6 for the most part. So infants also rely on their diaphragm during inspiration, and this means that they'll experience fatigue quicker. So they don't have the accessory muscles that adults have built up to compensate when they do have to increase their effort to breathe. Children, the most common cause of a bradycardia and cardiac arrest is hypoxia. So this is, if we need to correct this before that happens. If we can correct the respiratory failure, we have much better chance of survival than if it reaches cardiac arrest. So the cardiovascular system. So with adults, they can increase their heart rate and contractility. Children can only increase their heart rate. So you can have very high pulse rates to compensate for bleeding or hypovolemia. And you may not be able to see P waves when you hook them up to the monitor because their heart's beating so fast. So, and that's all compensatory. We don't want to give a medication to slow their heart rate down. We need to fix the volume. So we need to figure out, is this a cardiac issue or is it a volume or compensatory tachycardia? So normal heart rate for a neonate is 100 to 180 beats per minute, and then it goes down by a toddler is 90 to 150. So think about it, even a toddler has a fever, their heart rate could be 150, it could be even higher, and that's not anything to really, the heart rate in itself isn't anything to be concerned about. We're looking at why the heart rate is that high. And 6 to 12 years, even then, like the high end of normal is 120, and by adolescence it's the same as for adults, 60 to 100. So the other thing with children, and this is something that we're going to repeat throughout the lesson, is that they can compensate for shock for long periods of time, and they'll maintain their blood pressure. They may not even look that sick. They may not even look like they're in shock. So they'll compensate and compensate and compensate, and then they lose their blood pressure all of a sudden, and there's a sudden decompensation. Whereas with adults, it's usually more of a gradual decline, as they'll compensate and then there's a steady decrease in blood pressure. And with children, they'll compensate and compensate, and that's a sudden change. So hypotension in a child is a really ominous sign. That means when they've reached that point of decompensation, their mortality rate increases. So it's critical to detect when they're in shock and detect decompensation before hypotension develops. So with the heart, cardiac output is rate dependent, and the ribs are more mobile, so they're a lot more pliable, which means if they're injured, if the child's chest is injured, the ribs are going to come in. There's a higher likelihood of damage to vital organs. So the nervous system, so the brain receives nearly twice the blood flow, the relative blood flow than adults. So even minor injuries, if there's periods of hypoxia or hypovolemia, there's going to be decreased perfusion to the brain. So there's increased risk of hypoxia and there's increased risk of brain damage. So the spinal column, the fulcrum is higher. So the fulcrum between the neck and the head is higher and comes down. Fortunately, vertebral fractures are rare. Okay, the abdomen and pelvis, the organs are situated more anteriorly and are relatively larger. And in adults, the liver and the spleen are protected by the rib cage. With children, they extend below the rib cage, so they're vulnerable not only from the increased pliability of the ribs, but they're also exposed to things like seatbelts in the abdominal cavity. So there can be seemingly insignificant forces. And you think about like an injury in the car seat from a seatbelt, and they could be bleeding internally. And they can compensate very well before any signs of shock appear, and by the time they do appear, it may be too late. So that's why any kind of abdominal trauma, we want to have a high index of suspicion that there's internal bleeding. So with the musculoskeletal system, growth plates will be closed by late adolescence. Fractures can happen with low energy injuries. children are more likely to have fractures and sprains and strains because their bones are more pliable. And with the skin is thinner and it's more elastic. There's a larger body surface to weight ratio, and there's less subcutaneous tissue. So what this means is during burns, there's an altered rule of nines because the burn percentage over their body can be more serious and affect a proportionally larger area than it would be in adults. It also means that children are prone to heat loss and hypothermia, as well as hyperthermia, so they have less skin to regulate temperature than they do with adults. The metabolic differences: they have limited stores of glucose and glycogen. Newborns lack the ability to shiver, so they can't compensate for they're more prone to hypothermia. So it's more important that we want to keep children warm. Glycogen and glucose. So any children who's sick or in shock, there may be depleted. They're higher risk for hypoglycemia. So any child, anyone with an altered mental status, or any child with signs of dehydration or just generally sick and not looking well, we want to make sure we check the glucose. Okay, so that's an overview of lifespan development and anatomical changes in children.